Okay.
Yes. Thank you.
Sorry.
So to fill this gap, my colleagues and I started to embark actually on some work looking at improving originally the psychological resilience of cancer caregivers. And one of the things that we identified during this original study was that medicine management responsibilities was actually having a significant impact on their poorer mental health. And when we actually went into the literature and started to deep dive into this particular aspect, we actually found that this was also highlighted in a number of other studies, particularly in the fact that it impacts caregivers, both physical and mental health. So we started to embark on a new body of work, which was really looking to try and understand the experiences of informal caregivers in managing the medicines for their loved ones who were receiving cancer treatment. And we wanted to really, I guess, try and understand how we can help caregivers not only in these roles, but ensure medicine safety and reduce the burden that this role has on their healthcare, on their health. So to do this, we actually employed a mixed methods study. We did some interviews with cancer caregivers across a range of different settings. And we also conducted a national survey from November 2020 to June 2021. And just given the short presentation today, I'm just going to be focusing on some of the results from our national survey. So we constructed a 23-item bespoke survey based on our previous interviews, and it focused on three sort of core areas. Firstly, the medicine management roles that were actually being performed by carers. We also wanted to know more about the areas where they needed more support. And also we wanted to think about what were the preferences if we were to give them a support service, where they would like to receive that kind of support and from what type of health professional. And so we conducted this survey and we recruited participants for this through boosted social media advertising on Facebook. So once we had cleaned our data, we had 136 respondents. The vast majority, as you can see, were female. And the vast majority were also looking after a spouse. In terms of their particular medication management activities that they undertook, the vast majority attended appointments with their loved ones. They collected medicines and the prescriptions as well from outside appointments. They also had a significant role in administering oral dosage forms, and just less than half were also involved in preparing dose administration aids. We did find, similarly to previous work, that the psychological impact of looking after their loved ones' medicines was actually stressful, and it did cause anxiety. And more than 50% of our respondents actually said they really wanted more support, in particular around firstly recognizing side effects, and also they wanted just generally more information about the medicines that their loved ones were taking, because they were sort of feeling that they were out of the loop of that process. We also asked our caregivers to rank their preference from whom they would like to receive care from, receive a service from, I should say. And the most highest preferenced healthcare professional was the cancer specialist. Obviously, that is not always going to be practical for a cancer specialist to spend a lot more time with the carer and the patient going through their medicines. And so what we did find was the number 2 preference overall was the community pharmacist, which really helps us think about how we might design a future service. When we were also looking at where they would like to receive this service, and this actually echoed some of our earlier work in the psychological resilience space, they really wanted to receive it in a convenient location to them, whether it be during a home visit, so after hours, when they're not having to necessarily have significant care and responsibilities, or during a hospital visit whilst their loved one was actually receiving treatment. So just while they're waiting in the waiting room. So what this study has really done is it's highlighted that there is a need to support our caregivers in helping to manage the medicine management roles that they have, particularly to reduce their stress and anxiety. And we've identified, I guess, a range of settings and ways that we as community pharmacists may be able to support them. So that's my presentation today. So thank you.
So I have a lot of questions. Yeah, so I'll just repeat the questions.
Have you seen our work that we did in England? It's been quite interesting. So we found this incredibly stressful and that they were acting as professionals really in managing the medicines at home. But the difficulty was the medicines, especially at the end of life, keep on changing.
Yeah.
So they just couldn't keep up, and they found that incredibly stressful. But there was nobody looking after that, and the pharmacists were. And what my question is, how would you see the pharmacists doing that in the community pharmacy? Because they're too busy caring for their loved ones, especially at the end stages at home. They won't want to be visiting the pharmacy.
Okay. So the question is, what would be the role of the pharmacist, particularly based on the carer's preference not to visit pharmacists directly in community setting?
I think that's a really great question, and it's a challenge that we have. I think looking at our experiences in community, we do provide a lot of this kind of support, but it's not necessarily well received by the carer because they have the burden of actually looking after the loved one who might be waiting in the car while they're running in to grab the medicines, as an example. So I think what came out from our studies is that preference of that convenient location and the convenient time. And the convenient time is not necessarily during business hours, which was really interesting. So when we were doing the psychological resilience study, we actually had a partner in the UK, and we were trying to actually develop a service so that we have somebody who's available online during Australian working hours, and then we have somebody else available during the UK working hours. And we found in that particular study, that actually was quite useful to have, because we could have somebody during their normal work hours, albeit in the UK, answering calls from Australia and vice versa. So that was a really interesting thing that came out of that earlier body of work. How we do that here, I think there is probably the need to have more hands-on kind of service instead of something that could be delivered purely by telehealth. There is, I think, the potential for us to look at, for example, our accredited pharmacists in Australia who conduct home medicine review, and so looking at that as part of a future service. So I guess the next phase of this work is to sort of co-design that service and looking at what it may look like based on data we've already received.
We've got one more question.
Yeah, actually, we already answered my question. There are ways to have this with the home medicine review, and make it work since the caregivers are too busy for our new go. Yeah,
Answer the question.
Yeah, thanks, Ramesh. Not everybody gets the benefit of the Palliative Care Australia team who can come into your own home and help you manage that person. But there are pharmacists associated with that, but they don't sort of work full time. Would you see, there's there a potential model with that?
I think that's what we need to take our work to, is looking at how do we actually design this particular service. And that's the next phase of the study, is looking at how do we actually design the service to incorporate the elements that already exist, and also look at how we can utilise services like the accredited pharmacist model, which we do have a model in which somebody can go to the patient's home and actually provide a service, and looking at how we can harness, I guess, existing funded services for the purpose of actually supporting our caregivers. So I think that's the next phase of the work, and I acknowledge it's actually seldom known about those particular services, unless you suddenly get the call out of the blue or have been referred by a cancer nurse from hospital. Generally, it's not necessarily known.
Sorry, Miss.
Yeah, sure. I'll go to a question methods. I just wondered, so you mentioned that you recruited your sample by a boosted social media. What sort of, I guess, disadvantages are there in recruiting that way?
So the question is really around the method of using boosted social media as a method. I guess one of the advantages that we took advantage of was that how Facebook or advertisers, it's also based on what people are looking at, what sites they were looking at. So we're very fortunate to have Jacob Webb from a media team who specifically works in that kind of space, and he set up the advertising algorithm for us, and it was based on how how people were searching for things on Facebook or on various social media sites, and how Facebook was, I guess, picking up on the cookies and the data or the websites that they were looking at. So from that kind of perspective, it was advantageous because we were able to capture a large number of people who were looking at associated material. In some ways, it's also challenging, and we're not necessarily going to get a complete sample, which we acknowledge in terms of, if we, for example, had an advertisement on a billboard in the cancer service, obviously we could get probably more specific participants. But what we found, particularly from our stakeholders, from our earlier work, is they're typically not reading the billboards. They're not necessarily so engaged. They're much more focused on looking after their loved one or worried about the loved one whilst they're waiting in the waiting room. So we thought this was probably a better strategy to try and actually get as many participants in to complete our survey.
Thank you so much.
Thank you. Thanks, guys.
Yes. I'm just going to share the overall desktop.
And can you open up one there, presentation?
No, not that. John's presentation, where else is it? It's not.
Do you want to exit the share for now? Yeah, the presentation first. Yeah. And then share file. Share screen. Okay. Good. All right. Thank you, everyone. So I'm going to present John Jackson, who is a pharmacist with broad professional experience and expertise in pharmacy policy and governance. He's currently president of the Western Pacific Pharmaceutical Forum and chair of the Social and Administrative Pharmacy section of the Federation of Asian Pharmaceutical Associations, and the president of the Victorian branch of the PSA. So without further ado, I'd like to welcome John.
Thank you very much. Great opportunity to be here. I'd like to thank the organising committee, not only for organising such a great event, but for giving me the opportunity to speak to you today. And let's speak about something important. Let's speak about the money. As we all know, healthcare is increasing significantly in relation to GDP in pretty much every country around the world. And healthcare funders, be they national insurance programs like our PBS and Medicare, or private insurance companies, are really trying to do a lot of tricks to get better value out of what they pay, either by paying less for the same outcome or by getting better outcomes for what they actually pay. So we do know that there's a lot of payment methods that you can see some of them listed on the screen there that they can adopt. And one of them that I'm investigating in this work is a performance-based payment model. And so the objective here was to assess the existing fee-for-service payment model used for the pharmaceutical benefit scheme in Australia and determine whether a performance-based payment model may be an appropriate alternative. We used a couple of methodologies from implementation sciences and split that part of the research into really 3 stages: an assessment stage, fit and feasibility. Assessment was then split into 2. The first part of assessment was conducted in the United States, a separate piece of research where we studied through interview processes people who were running performance-based pharmacy payment models to determine what the key elements of such a model would be. And you can see them shown there on the top right. They'll come back in this study shortly. The second part of assessment and the fit and feasibility studies were done by interviews with key opinion leaders in the 5 socio-ecological strata of community pharmacy in Australia, down from the regulators and funders, through the pharmacy organisations, the proprietors, pharmacists, and consumers. And we hope to have at least 4 individuals in each one of those strata. The last part of this interview process examined whether a simple performance-based payment model would be acceptable to these strata in Australia. And you can see the detail there. It's based upon the idea that a pharmacist's counselling can improve adherence, which has got improved health outcomes and overall reduced healthcare costs. And so in this model, the pharmacist's payment would be adjusted depending upon some measure of adherence of a cohort of their patients. This is the structure of the interviews we conducted. The people were recruited, purpose sampling and snowboarding, sorry. And you can see our first task was to determine what those people thought of the existing PBS model, then look at the 4 elements of the performance-based pharmacy payment model, and in the last stage, assess that simple performance-based payment model that I just described. In the limited time, I'll quickly go through some of these results because I want to actually get to a more challenging point at the end, which is a potential alternative payment model. But there was universal acceptance that the current fee-for-service payment model is not fit for purpose. All it does is stimulate speed and volume of dispensing at the expense of quality and care. And that was an opinion that came through from all strata. There is actually no differentiation in payment depending upon any factor such as the risk associated with medication or the issues that the patient is experiencing. It became quite apparent to us that the payment model really should have some risk structure to it, and it should be split so that there is some payment that is technical, linked, paid to the proprietor, and that the individual pharmacist who does the work of dispensing should in some way be remunerated, because that would be one way of stimulating some form of improved performance. And so there were some recommendations coming to us that the payment model should perhaps mirror what happens with doctors, where there are short and long consultations. In terms of looking at the 4 aspects of the performance-based payment model, we identified through the interviews 8 types of services that could potentially be focused of a performance link. We tried to identify measures that could be applied to each of those, but there was poor correlation between any of the measures and in fact the services. We were hamstrung in terms of the payment models that exist, and people had trouble really at that stage identifying other payment models that could be applied. And the greatest barrier at all was the lack of ability to attribute the outcomes of a particular patient cohort with the efforts of a particular pharmacist or pharmacy. That being said, when we actually said to people, do they think a performance-based payment model should be implemented and could be implemented, taking into account the sample we discussed with them, the vast majority said there really should be some form of payments link in the payment for dispensing. Some identified this could be a real hurdle because of some of the vested interests that exist in the profession. And you can see there the support for this came from all areas, the business advisors, the regulators, and even the consumers. And the consumers wanted to be in on the act. They wanted some kind of financial recognition if they have improved adherence. So what do we do with this? We've got a scenario where there's support for a performance-based payment model, but because of the lack of correlation, it would be very difficult to implement. Well, our answer, and this was developed through inductive reasoning of the data that we collected, was to formulate this proposal. And that is, we do split payment for dispensing into 2. One for technical and commercial aspects, which goes to the proprietor. And there obviously would have to be some margin in there for sustaining business. The second would be payment for professional services, and that again gets split into two. One part of the professional services would be paid to the proprietor, and that would be for capital expenses, such as ensuring the pharmacy was accredited to a quality framework, for example, or that the staff of the pharmacy have been trained to a higher standard, is supported for some higher education, because we know these things contribute to improved quality outcomes. Or the proprietor might elect to introduce dose administration aid packaging and like. But the second professional payment should be paid to the pharmacist doing the service, and it should be a structured payment depending upon the risk of the drug or the patient, or a combination of both. And that would thereby motivate some form of improved quality that eventually you could adjust. So that's what we've recommended, and we wait to see whether this is something that will gain acceptance. Thank you.
Criminal body of work, and then have a question. I can repeat the questions.
Absolutely. I think, you know, the response you've got that everybody thinks this is a good idea, you know, you're after something. But how are we going to ensure that it happens as far as pharmacists counselling people? Because, you know, we all know that they should, but they don't. So how's that part of the question?
How do we ensure that the counselling occurs to be able to align payment? I'm not at this stage advocating that counselling and adherence be the measure. I think we're a long way short of that yet. Having looked very carefully at all of the criteria that are used in the United States performance-based payment models to adjust pharmacist remuneration, most of them have poor correlation with the activities of the pharmacist, and even counselling, which is the one that we could perhaps claim credit for, has so many other factors that could affect the outcome. So I think we're always going to be hamstrung with getting some outcomes, some services and outcomes that have high specificity and correlation. But it doesn't mean we shouldn't be pushing towards some recognition that a pharmacist who's committed to doing more for a patient who needs more should get rewarded more substantially.
Yeah, thanks. I'm just wondering whether some quality of life measure could be applied probably, I mean, as it says, by the patient.
So the question is whether a quality of life measure could be applied by the patient to this. And again, it is the difficulty is getting a measure that can be related back to the activity of the pharmacist. And quality of life, so many external inputs that, and as a profession, we're hamstrung in that regard.
Yeah, there are. I think there have been attempts to develop quality of life measures that are specific to medicines. So I think that's probably what's needed. That then, you know, that where there is that correlation. So then that would directly reflect.
John, thanks very much for a nice presentation. What's the experience of pay for performance in other health professions? What are the learnings?
It's a good one. What are the learnings and experiences of other health professions of pay for performance? Look, it's relatively widespread in the United States, not only for dispensing, but more so in some other areas of healthcare, medical practice, for example. It is also, I suppose, one place where you could consider it exists in Australia is hospitals that have to readmit a patient within 30 days do not get paid for the readmission. Now, there's an incentive to perform on the first admission. So there's not a lot of experience. This has been around for quite a long time. I'm not convinced, I'm not up here trying to say pay for performance is the answer, but I do know that the current model is broken and we need to find a new model.
Are there any drawbacks?
Yes, there are drawbacks. The experience, or my observation from the United States, is that the funding agencies, when they introduced pay for performance, used the opportunity to reduce the overall amount they paid for dispensing. They dropped the amount overall, gave people the opportunity of crawling or clawing back to the original level of payment if they performed greater than normal. But of course, just as many performed poorer than normal, and they were getting an even lower amount. So yes, there are definite drawbacks.
Thank you so much, John. Thank you so much. I'll just get that one. Which other screen? Take it off? Yeah, I'll just figure out how to share it first. 1 second. Okay, can you see that, Claire? Carleen, can you see the screen? Okay. Is it gone? Okay. All right. Thank you so much. And I'll just introduce Natalie. She's a pharmacist long involved in developing, implementing, and evaluating widened access to medicines through community pharmacy. And her vaccination work includes reclassifying multiple vaccinations to enable pharmacist administration without prescription, and is currently leading a team on interventional research project of funding maternal vaccinations through pharmacy. And without further ado, Natalie.
Thank you very much for 2 opportunities to speak today. I wanted to share the information in these slides because I was so surprised by it, and I thought it was actually a side effect of a delay in funding that gave us a different insight. And so this is the effect of promotion and COVID lockdowns on uptake of funded pertussis vaccination during pregnancy through pharmacy. So Tdap or pertussis vaccination given in pregnancy prevents pertussis in infants, which is something that can be associated with significant morbidity and mortality. And in New Zealand, we had a project in Waikato where we funded pertussis vaccine through pharmacies from late 2016. The research funding took a little while to put into place because we ended up having 2 different funders, which gave us a bigger amount of money so we could do more, which was terrific, but it took quite a long time to put into place. So we started with the intervention before the research could happen, and we're able to measure it later. So we ended up with 5 years of immunisation claims data from pharmacy, and we had interviews as well that we conducted about 2 years after the funding started. And the promotion occurred April to October 2018. So this is the maternal pertussis vaccination uptake over time, and we split it into 6 monthly intervals just to make it a little bit easier to look at. And you can see that when it started, and we did a little bit of training to start with as well. So for the first 18 months, there was fairly static take-up of the vaccines through pharmacy, around about 200 vaccines delivered through the pharmacies over each 6-month period. And then we did some promotion, and the promotion included a number of things that I'll talk about in a moment, but it was only for a 6-month period. And what's interesting to me, what was a big surprise to me, was that during that 6 months of promotion, we had an increase. And in the following 6 months, we had a further increase. Well, that's quite reasonable given that a promotion happened over that first 6 months. But then we kept seeing increases after that. So some of the promotional material was, things like posters and key points documents and things like that. But it was quite interesting to me that we sort of got this continued increase, this continued behaviour change. And then COVID hit in New Zealand, sort of February 2020, as many other places. And after COVID, we saw a decline in the uptake through pharmacy. And that was also quite interesting. So was it that the promotion had all worn off, or was it something else that was going on? And then if we look at the COVID lockdowns, sorry, this is a really busy slide, but you can see a big bulge from the purple in March 2020 with the pharmacy administration of the pertussis vaccine in pregnancy. And that was a reflection of a number of things, we think. And that was likely to be, and this is something that we, this is a guess really, everyone was tuning in every day to the Ministry of Health saying you need to get vaccinated for flu, and vaccination's really important, and everyone had this huge
thought about public health, which was really helpful. Pregnant women didn't want to go into general practice because they might catch COVID there, because someone might be in the waiting room with COVID. General practice didn't want to see anybody anyway, so a lot of them had their doors shut. So it made sense, and pharmacy were quite possibly offering more people the vaccine, and that was sustained through April with increased numbers as well. Now then, when we got to August 2019, and that's under number 2, it's the green bar, you can see we had another lockdown. So, you know, back in March 2020, we had our first lockdown started, but actually we had COVID in the community for a while before the lockdown, so it was a combination of things. We had COVID in the community again in August 2019, and we saw pretty much nothing. No one really cared anything more about going to pharmacy and suddenly getting all their pertussis vaccine. 2020, purple line, 2020. And then we managed to get rid of it again in New Zealand for a while with COVID. And we had another big lockdown that happened from August to, in some places, to December 2021. And that included COVID in the community in Waikato, and that's the blue line there. And you can see there that, again, that lockdown did not push people into pharmacy, which is quite interesting, did not appear to. And so it would be interesting to understand why, and I'm just sort of speculating why it might be, but we need some research around it, I think, ideally. We also, from the qualitative, what promotion actually helped. So that's 6 months of promotion. We did some promotion to pharmacists, quite a lot of promotion to pharmacists. We did some promotion to midwives, emails, and sending a video out and offering them posters. And we did some promotion to women through social media and posters in the pharmacy. And for the pharmacists, what really worked for them was 2 phone calls from the research group, talking to them, finding a champion for pertussis vaccine in the pharmacy, and talking to them about the opportunity to look for women getting prescriptions for folic acid or iodine, which happens in pregnancy in New Zealand, and look for those and start talking to them about Tdap vaccine, and also to make sure that their whole staff were informed. That was the number one thing that worked, but also posters were a useful reminder, and we did staff quizzes for the front of shop staff, so to try and find out, because they're in a position to be able to identify pregnant women as well and have a conversation and point them out to the pharmacist. We did find a really big variability in pharmacy proactivity in their use of social media. So we would send off social media stuff, but that was the cosmetic side. They didn't want to know about it for the prescription and pharmacy side, the medicine side so much in some pharmacies. Staff education, and some of the pharmacies we suggested to all pharmacies that they call their local midwives and let them know that they're doing the vaccines, and some of them did it and some of them didn't. And where the pharmacies weren't doing the vaccinations, they didn't use any promotion and didn't seem to know anything about Tdap to be able to talk to patients. The midwives, where they received pharmacy calls, they really appreciated that. But generally they didn't want the posters. They didn't seem to be influenced too much by the emails as well. But some of them chose to recommend pharmacy, and some of them also got some word of mouth. And I think that was part of that delayed effect that we saw from the promotion, was that women would come into them and say, oh yeah, I got my Tdap vaccine at the pharmacy. So they, oh, okay, right. And so the women were sometimes giving that information to the midwife, which was helpful. For the women, the number one thing there was the healthcare promotion, the healthcare professional saying, we recommend you have a Tdap vaccination during your pregnancy. That was the number one thing. And although they said, when you asked, well, what would you recommend? They all said, a number of them said leaflets, but actually no one seemed to be influenced by leaflets. There were leaflets available, some had them, but everyone, it was about the healthcare professionals. So our work on behaviour change with midwives and pharmacists and general practice, I haven't included the general practice here, but our behaviour change at that level is actually really important to help women become aware and have the opportunities to be vaccinated. Social media, the people who we interviewed had real suspicion, and they didn't want to be influenced by social media. They saw it as being very biased, and that was quite interesting to us. So they wanted balance. So in conclusion, we found a remarkable sustained effect from promotion, and I guess that was confidence gained as well over time. COVID increased pharmacy uptake initially, but then I think that because of the pressure on pharmacy with COVID and exhaustion, midwives were under huge pressure in that time too, so may not have had the same amount of time with patients to talk about maternal vaccinations. We saw a drop off in what was happening through pharmacy. And I think it's useful to examine optimal timing for repeating promotion. Thank you.
On few cases where COVID works in favour of research implementation. So, do you have any questions?
Yeah. I wonder whether vaccinations for that condition changed in any sorts or all sources in New Zealand during this time, and whether that could inform some of the interpretation.
That's a really good point. So we got quantitative data through to pre-COVID for our main analysis to show whether pharmacy made a difference, but we didn't have access to it after that. And it would have taken quite a lot of time that we didn't have funded to do a further analysis, whereas we could still do a bit of an analysis on pharmacy. But that is a big question of, did it actually have an increase in uptake overall, or did it just move some from doctors? And I suspect that in that first big wave that we saw with COVID, lockdown and the COVID in the community, I suspect it was mainly a move from doctors, actually. That's my guess.
Yeah, the hope would be that you increased overall, if that was sustained.
Yeah, so we did have an increase overall. So the data that we saw pre-COVID showed an increase overall over that time as a result. And so we got, and general practice still increased a bit. So we actually had in the main study a control group and an intervention group, so 2 control regions and an intervention group. And so that's been published, and it shows that particularly for Māori women who have really low vaccination rates for maternal vaccines, often because of non-awareness, that increased significantly for them because of the pharmacy funded model. But there's still a lot of opportunity there. One of the biggest problems was that a lot of pharmacies didn't do vaccinations, particularly in rural areas where there's a few more Māori people as well.
I'm just thinking of the change topics. Those services, you know, I'm thinking full maternal flow through pregnancy of all these pharmacy services versus I suppose a siloed delivery of the same thing. Opinions?
That's always a criticism you can make of the health service, and you know, I've been working in a funding model more recently, and you get this, you know, sort of thing from above. You need to work on this, or you need to work on that, and this is what the funding is for. And so it is actually quite challenging. The funding is not typically for a whole approach to maternal health, for example. So you know, we've got some money at the moment for catch-up vaccinations that we're working out. Okay, we've got something where pharmacists are doing some work around that, catch-up childhood vaccinations, and we've included TDAP in that, and messages around going to see your doctor afterwards. You know, make sure you have your on-time 6-week vaccinations and things like that. But the way that the funding envelopes tend to work is for this or for that. I'm working on a Hep C thing. Actually, it's quite helpful to have Hep C and Hep B screening at the same time for some of these populations, but it's different money. So it's hard to resolve in the way that our health system is set up and our funding is set up in New Zealand, unfortunately.
Any other questions?
Thank you.
So that's a wrap for this round of presentations, and we have a break coming up, and enjoy your time. Bye, Kelly.